Everyone, and welcome to this third lecture on a case history discussing about a young patient presenting with chest pain and shortness of breath. So we were talking about the ECG of this patient. In the last slide, we were talking that the ECG of this patient shows RR interval variation, and we had discussed about the reasons for that it is quite common in young people, and there is beat-to-beat variation normally appreciable. The second change in the ECG was ST segment elevation. Now let's talk a little bit about a differential diagnosis, or what are the main causes of ST segment elevation in an ECG. So starting with the most sinister ones: acute myocardial infarction, or a heart attack which takes place when there is occlusion of a coronary artery branch that can cause to necrosis of a portion of the heart muscle. Coronary vasospasm, which is called as Prince-Metal angina, is spasm of the coronary arteries, which may be temporary and takes place during exertion and is relieved by nitrates. Then pericarditis, inflammation of the pericardium, can lead to ST segment elevations. Benign early repolarization, which, as the name suggests, is a benign disease, a benign disorder seen in young people due to early repolarization of the myocardium. Other pathological reasons include left bundle branch block, left ventricular hypertrophy, when the heart myocardium on the left side is more thick or hypertrophied as compared to a normal, which is commonly seen in hypertensive patients. Ventricular aneurysm may be another cause of ST segment elevation, one of the sinister ones. Then there are some conductive disorders such as Brugada syndrome, which can lead to this. Ventricular paced rhythm, raised intracranial pressure, and a congenital cardiomyopathy called as Takotsubu's cardiomyopathy. So these are some of the differential diagnoses of ST segment elevation in an ECG. But let's discuss what can be the cause of ST segment elevation in this patient, keeping in mind the history of this patient, as this patient is a young person, otherwise fit and healthy, is not diabetic, doesn't smoke, and clinical examination shows normal blood pressure. Echocardiogram was also done, which shows no abnormality at all. So what would be the most possible cause of this change of ST elevation in this patient among the list which we just discussed in the last slide? We have to focus on more benign causes of ST segment elevation, and in this patient the most likely cause would be benign early repolarization, as we have mentioned in the slide previously. So what exactly is benign early repolarization, or BER? This is usually benign ECG pattern producing widespread ST elevation that is commonly seen in young healthy patients less than 50 years of age. This is also known as high takeoff or J-point elevation, and it may mimic the ECG of pericarditis or acute myocardial infarction. So what are the ECG features in BER, or benign early repolarization? First one is widespread concave ST segment elevation, most prominent in the mid to left precordial leads V2 to V5. Secondly, notching or slurring of the J point. We will discuss about that in later slides. Thirdly, prominent or slightly asymmetrical T waves, which are concordant with the QRS complex. Concordance means the direction is the same as that of the QRS complex. non-reciprocal ST depression to suggest occlusion myocardial infarction. There won't be any reciprocal ST depression, which is suggestive of occlusion myocardial infarction. So this is an ECG. As you can see, this is the ECG of benign early repolarization, and you can appreciate the changes which we have just discussed in the previous slide. So this concludes our lecture regarding BER and possible cause of ST segment elevation in this patient, and we will see you in the next lecture. Thank you very much.